The proceeding will start shortly. 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 The proceeding will start shortly.
Welcome to our session which is examining the implications of the budget for health and social care, and so welcome to our first panel, and Richard, just to say congratulations on your new appointment, and so could I ask you to introduce yourself to those following from outside the room, starting with yourself, Sally Gainsbury.
Sally Gainsbury, I'm Senior Policy Analyst at the Nuffield Trust think tank.
Anita, Charlesworth, I'm Director of Research and Economics at the Health Foundation.
I'm Richard Murray, I'm currently Director of Policy at the King's Fund and Chief Executive Designate.
Thank you. Could I start, first of all, by looking at that discrepancy in the Budget Red Book between the spending on the Department of Health and Social Care and NHS England? And perhaps if I could go first to yourself, Anita Charlesworth, to look at, because I know all of you have raised concerns about that discrepancy and what this means, to give your overview of what it means for non-NHS England funding, and perhaps set out for those who are following this debate why this matters and what it means.
So the budget confirmed that for NHS England the allocation will increase by £20.5 billion in real terms by 23-24, in line with the Prime Minister's commitment in the summer. In the summer, they had indicated that they knew that pension costs were going to be increased and there would be some additional funding to meet those pension costs. That next year, that's £1.25 billion for NHS England, and the budget confirmed that that was added to the NHS England number. The issue is that the government said that decisions about departmental budgets are for the spending review, which will occur in 2019. There is some money in the budget arithmetic for additional pension costs across government, but they have not yet, they didn't in the budget commit firmly to increase the Department of Health's allocation overall by that same £1.25 billion. If they do increase the Department of Health's allocation next year, then we're where we thought we were, which is still with issues around the budget for education and training and public health grant and capital that come out of that central pot in the Department of Health. If they don't increase it next year, and of course the spending review will happen after the start of the financial year and is principally for allocations for 2020-21 onwards, then it leaves the department's central budget £1 billion, broadly speaking, just over £1 billion short. That budget covers things which are really important to the delivery of healthcare. So it covers the budget for education and training, for new staff and existing staff to upskill. It covers critically the public health grant to local authority, which funds things like smoking cessation services, sexual health services, already being cut. Many of those things are really important as well, not just in their own right, but important things for how efficiently you can spend the money out in the front line of the NHS. So we obviously know that if you've not got enough staff, NHS has been forced to rely on agency staff, which are more expensive. So I guess there's a kind of double whammy impact if that money isn't forthcoming next year. The department could, the Treasury could give the department more money. Even now, we've not reached the point where they can't add that total for next year, but the local government allocations for public health are due in December. And Health Education England needs its budget before the start of the financial year in order that it can plan training places. So they can't leave it to the spending review, I think, because they would push the department into a position where it's setting budgets for its agencies that it hasn't got expenditure to cover, and that's not appropriate, obviously, for a accounting officer in a department to do. So it's not that it's impossible for them to do that, but time is running out, and it is perplexing that you would make clear that for NHS England you were going to do that, but not make clear that you were going to do that for the Department of Health.
I don't know, do Sally and Richard want to add to that, or would you agree with that assessment?
Well, we agree that, just like to add that what Anita's saying there is that reductions to the Department of Health's much smaller budget really does have a direct impact on the frontline NHS, which is, of course, the bit of the NHS that the Treasury is trying to protect. So, for example, hospital trusts lost in the region of 50 million over the last 2 years in funding for education and training placements for nurses and medics. So that's a direct hit on the hospital trusts, which, as we know, are currently in deficit. In addition, we think there's been some substantial losses from R&D funding that have come from the Department of Health central budgets to, NHS provider have been used to receiving around about £1 billion a year in R&D funding. That's reduced, we think, by around 100 million over the last 2 years as well. So that's another direct impact of reductions in the Department of Health budget, in addition to, we think it's around 100 million real terms reduction in public health spending a year since the Spending Review 2015. So, yeah.
The only thing I'd add is just to remember 1 billion up against NHS total funding may not sound like a particularly big number. The department doesn't have many budgets left. Public health, the training budget, those are the giants of of the money that it has left. So 1.25 billion off of that is a startling number. Even if you told HEE now that it was going to lose the money, whether or not it could bring down its spending fast enough is a moot point. So there is even a deliverability point about this, that it's very late to tell people of quite a big shift in budget. So we're all hoping that some point early in the new year we'll see the money reappear back in the department's budget.
Particularly worried because of the amount of resource the DH is having to put into contingency planning in the event of no-deal Brexit. They've had to put quite a lot of... They can't cut that part of their resource. So do you see anywhere else they could take it from?
It's really hard to see where you would generate 1.25 billion, frankly. I should say there are a couple of ways in which the department gets income. It can get income from the drugs companies through PPRS. There is a new PPRS deal coming, we expect. These may generate some money for the department, but 1.25 billion is a striking number. Like I say, it's big enough to mean it's even questionable whether people like HE could bring their spending down that quick, even if they tried to.
Had this kind of transfer. It actually came from cutting bursaries, as I recall. There's absolutely no fat on the bone, is there, when it comes to HEE's budget now? No.
Indeed, some of the funding we saw here in the NHS for sustainability also came from the department, so we think they've effectively cleared out all their own contingencies already, so there isn't anywhere else to go.
So you can't see anywhere else it could come from? Thank you very much. I mean, do you think it would be better if some of the increased funding for the NHS went to other areas covered by the whole of the NHS England budget, the DH budget rather? In other words, should it be spread more fairly over things like public health and health education and training?
Well, it's slightly odd at the time you're constructing a long-term plan that the pieces you hold out of the long-term plan are public health, the training of the workforce and capital spending. So the three things that really you do need to know about for the long term are the three things that aren't in there. I think you could use some of the money that will be given to NHS England to do that, but you need to be clear then that it's not quite as generous as it appears if it's going to start picking up pressures in other parts of the health budget.
And I think the point that has been made in evidence to us is actually it's not a 3.4% increase, it's more like a 2.7% average increase. Is that? Would you agree with that figure?
So if the extra funding for pensions doesn't come through, then it would be 2.7% a year increase on the whole health budget. That is below the estimate in the work that we did with the IFS of the minimum that you would need to stand still, which is 3.3% a year.
Substantially lower, and then we're going to come on and look at in more detail at some of the other things that might make it worse still. But I'm going to come on now to Rosie.
We're looking at inflation and looking at some of the things that have been written. Higher than expected inflation means that we're going to be needing something like another 260 million straight off from the Chancellor. So I suppose my question would be, you highlighted the fact that higher than expected inflation means real terms increase is now smaller than we'd expected. And how will the higher than expected inflation on top of that hit health budgets in practice?
Yeah, so I think the Treasury has said that for the spending review, it will reset the cash amount that it's going to give the Department of Health and NHS England up to 23-24, so that in real terms that does add up to 20.5 billion, which was the Prime Minister's commitment. Now, it's going to do that. So I think what it's going to do, the next set of economic and fiscal forecasts will be in March, which the OBR will produce, and they will set out a set of inflation estimates at that time, including the GDP deflator, which is the inflation estimate that the Treasury uses for these purposes. So I think we can expect that they'll fix the amount at that point. If the inflation estimates stay at the ones that were in the budget, that's 260 million extra for 1920. It's $1 billion extra in 22-23. So this might sound like some micro-technicality. What I think we're saying is the treatment of pension costs and the treatment of inflation are not micro-technicalities. They produce big numbers, which are really important. Bearing in mind as well, when you add up the pressures on the system from the ageing population, rising chronic disease, rising input costs, because we are now having to pay higher pay awards, and NHS pay is going to go up, certainly for Agenda for Change staff, by more than inflation. There is sort of less than $1 billion left in this announcement for purely discretionary purposes. So, you move a little bit either way in what seems like a technicality, and it has a very big impact on your ability to invest in change.
So how does, if NHS inflation is ahead of economy-wide inflation, how does that factor in on top of all of that?
Well, so there are a couple of things then. I mean, it's very difficult. They don't produce an NHS inflation index anymore. And working, you've got pay, and we know that pay has obviously been held down for recent years. We know now that for the next 3 years, pay will rise by more than inflation. That's one of the reasons, and for getting the 20 billion. Working out what's going to go on with drug costs, I think, is very, very difficult. As Richard said, the PPRS deal is up next year. I mean, we've always done quite well in negotiating that. NHS England and NICE have negotiated a new arrangement for drugs which are going to have a large impact on the budget of the NHS to try and strengthen our negotiating hand. We've done very well in the UK in the move to generics, but with the Brexit vote, the pound has moved against us. We import a lot, and obviously industrial strategy post-Brexit may mean that it's particularly important to us that we have a good and constructive relationship with the pharmaceutical industry, which are a very important contributor to economic growth and jobs. So where all that, I think quite how the drugs piece, which is the second big area of cost, play out, quite difficult to know.
I should just probably just add that this is happened before. So this isn't. I think the piece about the healthcare inflation is not a piece of sleight of hand. It's always difficult to work that out, and the health service always carries a risk, particularly around pay, that might move faster than the economy-wide inflation. There is a particular set of uncertainties now, obviously, around some of the prices of other things like medicines.
So we have done some estimates, and at the moment it's looking that for NHS providers in particular, so around £85 billion expenditure, inflation for them over the next couple of years will be around 3%. So that's a full percentage point above whole of economy inflation. So also when the Treasury talks about real terms increases, the reference points there's a whole economy of inflation, so there's roughly another £1 billion of cost pressure on top of that. As the others have said, there's some uncertainties around drug pricing within that, but the main change is obviously on the pay deal. There is substantial uncertainty, however, around the pay deal as well, because although we know the headline cost of living increases, what we don't know is what impact the Agenda for Change pay deal will have on pay drift. So that's how much pay expenditure goes up because people are rising up through their pay bands. And obviously as part of the pay deal, there has been a substantial change in the pay bands. Now, the point of those changes is to recruit and retain more staff. In very recent years, pay drift, so the amount pay goes up depending on how people rising up, has actually been negative, and that's been because people have been leaving at the top of their band and being replaced by people who are cheaper, either at the bottom of their band or people on a lower band. We now have a new deal, which, if it's successful, will stop that happening. So potentially, pay drift is going to stop being negative and will actually be substantially bigger. And you might want to explore this Department of Health. My understanding is there is quite a wide difference from what the Department of Health estimates pay drift will be going forward, which is around 0.1%. I think the 10-year average has been about 0.6%, and some local modelling from trusts I've spoken to, which is near of the 1%. There's about £400 million difference between that for the cost implication for NHS providers. So quite important to get to the bottom of, but actually some of it is just naturally uncertain because we don't know how the pay deal is going to play out in practice.
Can I ask all the panel what the health service can do to shield itself from higher than expected wage and price rises? Is there anything it can do to shield itself?
Obviously, on pharmaceutical prices, yes, it's almost a monopoly buyer. And so as long as it uses that power well, it can provide some degree of protection from both higher prices and from drugs that don't seem to work as well as we might want them to. I think pay, obviously, again, the government can set pay. I think the thing on pay you really need to remember is if the NHS also needs to be a good employer. And so if you reach a point where the combination of terms and conditions of pay, of the working life get too bad, you drift into a workforce crisis. And I'll tell you, it's an awful lot more expensive getting out of a workforce crisis when you're in it than avoiding it in the first place. And I think that is one of the risks we're facing.
On the pay front, one thing that I think it's quite important as well to bear in mind is whilst the NHS pay deal, Agenda for Change pay deal, is funded as part of the settlement for an NHS England, local authorities are very conscious that at the lower bands of the pay scale, social care is often fishing for the same pool of workers as the pool in the NHS. The NHS, for very good reason, this pay deal gives a big increase to the lower level starting salary of people in the NHS. The Association of Directors of Adult Social Services have estimated that if social care tried to match that, it would add £3 billion to the budget for social care. There is no provision for the knock-on consequences. And bearing in mind already the issues about high turnover problems, recruiting and a reliance on an EU workforce, and the Migration Advisory Committee and its advice to the government around a post-Brexit migration policy said very clearly that they were not minded to recommend a dedicated route for social care, but felt that the problem was in the pay terms and conditions of social care staff. But fixing that is very expensive, and there is no margin in the amounts that are currently paid to providers for them to fix that.
We'll probably explore that in more detail with our second panel, but thank you for raising that now. Did you want to add to that, Sally? No? Yeah, thank you. Ben?
Why does this government keep doing this, keep cutting public health and social care, which saves the NHS money? Why this Treasury fixation with giving what small increases there are to hospitals, which only ends up making the whole situation worse? What's the cultural problem, Anita?
I think it largely reflects I think there are two things. It's been easier to do in the short term. I also think we're not.
Why?
Because it's less. I mean, in essence, you're caught between the devil and the deep blue sea, aren't you? You have full A&Es and full hospitals you can't discharge patients from. That is a here and now emergency situation. You know that you're locked in a vicious cycle, and there is a better way of delivering care fundamentally that would use resources better. But if you've got constrained resources, you can't afford the double running. You get stuck in a position where you're compounding the problem because you can't see a way of breaking out of that vicious cycle. I also think we've been very ill-served by the language of frontline, where we've so actually now creating this separate so-called frontline NHS budget has underplayed the extent to which then things like many of our public health services are absolutely health visiting, what people would understand as a core service. These are not discretionary add-ons, and I think some of that narrative has made it easier as well to appear to be cutting things which are a lesser priority.
I mean, the Treasury is full of extremely intelligent people. They're supposed to be the brightest department in Whitehall. Why don't they understand that? Or why can't the health department persuade them of the lunacy of their current approach?
It's a hand-to-mouth situation in essence. So last year, $1 billion extra was allocated to social care to cope with winter pressures. NHS Improvement reckon that saved 21 million in delayed. So you spend $1 billion, you save 21 million. Of course, in a situation where budgets all over the place have been squeezed, you're maybe not going to be spending another $1 billion. The time scale for the payback is too far off.
If you had $1 billion now, would you put it into social care? Yeah, you would. And so, what's the impact going to be, do you think, on the NHS of the ongoing future cuts to social care in terms of the NHS being able to deliver?
I just want to say one thing. The point of funding social care is for people that need social care services. So I think one of the things we get trapped in is how much of a bang for your buck does spending on social care give you to the NHS? And it focuses you back onto the A&E department. But older people who may be struggling to live a reasonable life really need social care, and it's not just a means to help the NHS. I just wanted to say that before going on. It's actually quite difficult to specifically identify how cuts in social care hit the health service. I don't think anybody doubts that they do. But in the short term, you'll find carers trying to step in. They'll take the stress, they'll take the burden. Health service might not see it immediately. When people are actually arrive in A&E, it can be difficult to know why they got there. How can you track back what might be quite a complicated pathway of care? And so although I think most people in the service absolutely believe in the link, it's tricky, I think, if you're sitting in the Treasury to work out exactly how much is that worth. If what you're focusing on is, I just want to save the NHS, I'm actually not that bothered about social care. And I think we need to, as we've done with mental health, raise the visibility of how important social care is, not only because of its links to the health service, but because of an end in itself. I think if you keep on cutting it, if you keep on cutting public health, we'll continue to see emergency admissions to hospital rising. I think they'll always rise, but you get extra admissions to hospital because of it, even if it's not always easy to say, will it be this year, will it be next year, will it be the year after? You get caught the system on a treadmill, and it's not only about social care. We've seen staff in community health services shrink, we've seen the number of GPs shrink. Eventually the system will give all of the resource to the acute hospital, and you can't cut them. Their beds are full. Their beds are full and the A&Es are full. It's trying to run a little bit faster to get ahead of that rise in demand.
Can I just slightly challenge that briefly? Sorry to jump in, but I was up at my local hospital about 3 weeks ago, and they gather all this data, right? So in terms of, for example, the over 65s, they've seen a 14% increase just this summer. And concomitantly, you've seen the decline in social care. So I think to say that data's not available is slightly sort of giving too much to Treasury. Whereas, and in sort of layman's terms, I mean, Ben's hit the nail on the head, where is the missing chip that says, actually, if you take all this money out of public funding, right, that is going to have a direct effect. You say admissions will go up, they will always go up. But at the rate they are now, it's never increased at that rate now.
Absolutely.
So why are they still sort of missing that pretty fundamental link? Is it a culture thing?
I'm sure it is partly a culture thing. I think it is partly searching for the benefit for the NHS. You can quite easily make the case for the benefit of social care for social care. I think again, at least at a statistical level, England, you get numbers like $1 billion in health generated, 21 billion in savings. It doesn't really seem to stack up. It's quite a difficult piece of math to do, even if everybody working in the service absolutely understands it. I think the other tricky thing about social care is, I'm sure I'm only going to tell you something you already know, is a long-term solution to the funding of social care is quite hard. It has been elusive to more than one government. If it was that easy, I'm sure they would have done it. The temptation instead is just to top up each year, 400 million here, 500 million there, just to push the problem slightly down the road. But the problem, unfortunately, just gets bigger.
And the social care system we have anyway is a social care system that's only focused on the most critical of needs. It's not a social care system that's preventative or looking at preventing loneliness or preventing those higher critical needs, and that's been the case for the last decade.
I think it's a really important point that it's not just social care. We've also seen over the last few years that despite clear stated policy ambition to move all services to a more preventative, earlier intervention, community-based model, we've seen resources actually come away from primary care, move away from community. And one of the things that and so I think I'm a former Treasury official, so if I was thinking to, one of the things that my ex-colleagues are seeing is that if they give them money badged for prevention, and they would argue that they led the way in the Better Care Fund, for example, to try to rebalance that, what happens, even when they give it in dedicated way, is all the resource gets sucked into the acute. And I don't think the central government is fully confident in the Department of Health and the NHS's ability to direct any additional resource into the areas of service that they really need. And the misalignment with workforce planning is one of the things that gives them, I think, anxiety, which is not completely unjustified.
I guess brings us on to talking about public health funding. Isn't that a case then for increasing the amount of money that's going into local authorities to deliver health visiting service, sexual health services, substance misuse services?
Yeah, I mean, I think it clearly is. There is. I think Richard's point is really important. Public health. Things like sexual health services, health visiting, they matter in their own right for the outcomes for people as service users. They shouldn't be measured purely in terms of their ability to reduce demand on the acute system. And if we look at the cost effectiveness, and bodies like NICE's work looking at the cost effectiveness of those public health services, they are very, very high. And there is no logical basis, really, for the scale of cuts that have been made to public health, and it is completely contrary to all the policy narrative that we've had for the last decade at least.
And Sally as well.
I think that's absolutely right. The only thing I'd note is when Treasury has handed over the money and the department's hoped some of it might go into whether it's better care or more preventative services, you have to meet the costs of the acute sector. Just to reflect the pain of people who work in acute hospitals. They haven't got their feet up on the table. They're deeply stressed and very, very busy. And I think part of the problem is coming up with overly optimistic assumptions that the acute sector will be suddenly dramatically more efficient, that one of these levers we pull in the community will suddenly cut the number of people going into hospital. They don't. They often take a bit more time to work. They're not quite as dramatic as that. And so you get presented by a slightly unreal set of numbers that assume the acute sector will shrink. Well, it won't, and it hasn't. And the money then gets drawn back out of all these other pots to try and prop them back up again.
And of course, many of the benefits of public health spending are not felt in the acute sector or indeed even in the health sector. My local chief constable tells me that it's money spent in substance misuse services that make the biggest impact on some of the levels of crime associated with substance dependency. So What would need to happen in order for either Treasury or the Department of Health to be able to make that public health spend?
The overall budget needs to be larger. That's it. As Richard's just said, it's not that the acute sector is being particularly privileged. We've almost had a decade now of hospitals being paid 4% less year after year in real terms for a decade. Which is why they haven't been able to keep up with that. Their costs have not been cut. They haven't been able to cut their costs by that amount. But that's what they have been trying to do, which is why they have ended up in deficit. So the reason why public health, social care are underfunded and community service and primary care is the overall pot has not been big enough. It's not that there's a load of fat is stuck in acute hospitals.
So if you met the legitimate costs of the acute sector, but then ensure that absolutely everything else gets swept into the community, into these more preventative services, because of course if you did meet the demand in the acute sector, there is a risk then that they'll just keep on going. More additional services, more high quality services, wonderful in their own right, absolutely. But once those core costs have been met so that they can meet the demands of today, to try and make sure all the additional money and all the additional workforce goes in trying to protect the future.
It's possible for the NHS to meet its stated demand of stated aim of reducing demand through prevention before we know what the public health settlement is going to be for the next few years.
There's no funds for investing in that prevention, so it doesn't make sense that you can reduce the demand curve without having it, without investing in that first.
The government's just announced. We had a big statement last week, week before, about its prevention strategy. Is the problem that is largely secondary prevention, rather early detection, rather than primary prevention?
Yeah, and of course, one of the biggest drivers, as the strategy recognised, of ill health is wider social determinants. So the relevant thing here is not just spending on things which are badged as health, but spending on education, on community infrastructure. You were talking about the issues for your chief constables, the impact on things like custody youth services. All of these different activities obviously shape as well the health need that presents itself. And I think one of the things that is interesting is and a weakness of some of our debate and the way we do things like public spending reviews in the UK is we conflate NHS and health. And we don't have a wide enough conceptualisation of health. We don't think in things like the spending review properly about all of the different contributors to health, how our health needs are changing, and therefore what that means for public services and welfare as a whole. And I think one of the things that one could challenge the Department of Health and Social Care on is, just as they've always been responsible for social care but wasn't necessarily always very visible, it is a different thing to be a Department of Health as opposed to a department for the NHS. And they've been a better department for the NHS than a Department of Health.
I guess on that note, thinking about the wider determinants of health, particularly the impact of income and of poverty on health, are there ways that the Chancellor could be better using the tax system to improve public health?
You think of some of the most impactful things on people's health, it's been the reduction in the use of tobacco. And I'm sure NHS stop smoking services were helpful in that, but so was punitive taxation and steadily tightening regulation, which to some extent don't cost the public sector at all. And if done right, they're also light touch on, we don't always like regulation, but can be light touch on the private sector. So it's opening out that conversation to say there are some levers around spending, and I think Anita's absolutely right. The department has been a department for the NHS, and so its mindset is, how can I use NHS staff to impact on prevention? And they should think that, not always think about the full range of levers, many of which are held by the Treasury or other government departments. And I think the slightly, let's face it, impressive success of the sugary drinks levy that hasn't forced people to think through difficult decisions, perhaps but that's what we want them to do, about changing their diet. It just led many of the companies to reformulate their drinks, and nobody notices that the sugar content's gone down. And I think that was quite an innovative policy. What the Secretary of State said last week in the vision is we're going to have a green paper coming. I think what we really want in that green paper is thinking about some of the spending levers, thinking about how other parts of the public sector think about health and how health think about them, but also that we get those other levers, the things that really worked on tobacco, the things that appear to have worked on sugary drinks. Again, so we don't get trapped purely into a conversation on spending, partly because I fear the NHS, where a lot of that money would get spent, if you are using money, probably hasn't got the staff to do it anyway, not quickly.
I guess on public health spend is that some of public health spend tries to alleviate health inequalities. What evidence is there that inequalities are kind of fueling the demand for NHS services?
Well, I mean, so it's very clear that there is there's a gap in life expectancy, obviously, between those in highest income groups and those in lowest income groups. But the bigger gap is in healthy life expectancy. And healthy life expectancy for people in the lowest decile is something like 18 years. I'll write to you with the right numbers. It's something like 18 years below life expectancy. So we've got a substantial group of people who are living with multiple chronic conditions, with also very difficult social circumstances that make delivery of care more challenging, and we have a resource allocation formula in the NHS that tries to move money around to reflect that. This is also one of those areas where thinking more broadly across government is really important, because I think it's the lowest, at least 30 or 40% of the income distribution have a healthy life expectancy, which is way below the pension age. So if you've got then the impact on the health service of higher need, but then also you've got people whose ability to work is being affected, which impacts them now, impacts the Treasury now in terms of benefit payments, but also means that they're not in a position to make provision for their own old age and their retirement. So again, that is a lose-lose, very, very clearly. So I think there's a strong case to be made that a focus on inequalities, and really hope that the new long-term plan will make that, is the right thing to do, in terms of social justice, but also it makes absolute economic sense.
Just say on that, we do have an allocation formula that will nominally send more money to areas of higher deprivation, or at least they have a higher allocation target. But the problem we've had in recent years is because the overall funding increases each year have been so small, it hasn't really been possible to send more money to those poorer areas, because the only way you could do that would be to actually cut the allocations of areas which are nominally overfunded. And I don't think any of you would like your constituency to be one of the areas with actual cuts. So there's been a principle that everyone's had a sort of a similar baseline uplift, and the extra headroom that's been available for giving more to those poorer areas which are acknowledged as poorer and needing more funding, that hasn't been there, so that just hasn't happened.
Thank you. Just before we leave this area of prevention, Richard, I know the King's Fund has done quite a lot on social prescribing. I've just come from a meeting with a group called Dance in Devon that do fantastic work on falls prevention through exercises and dance. Where do you think that the funding for social prescribing schemes and voluntary services doing fantastic preventive work, where do you think that should best come from? Should that come from CCG budgets or public health budgets? Where do you see the future for that?
In a practical sense, at the moment, it's probably only the CCGs that have the financial depth to do it. After what we've said about the problems with some of the public health budgets, looking to them to do it on their own, I think, is a big ask. We did ask the Secretary of State, was he happy to see NHS money going to help support those schemes? And he said absolutely yes. I think they probably don't need much money, but they do need some. They need a bit of seed funding to get them off the ground, and particularly for some of the real enthusiasm we've seen amongst GPs for them, because I think for many GPs, it just ends up being very stressful, having patients sitting in front of them that they can't help, that they know that they're suffering from social isolation, that they're trying to medicalise something that isn't really necessarily the medical solution is the right thing to do, but it needs a bit of seed funding to do in order to be confident that these programmes work, confident that people are attending things that are okay, that are safe. And so I don't think it's much investment, but it does need to come. And I think at the moment it's really only the CCGs that have the room for manoeuvre.
See that happen as
yes.
well. Thank you. And we come on now to capital investment and Andrew.
Thank you, Sarah. So we know the capital budget has been rated to balance the books in previous years. What's your assessment of the impact that's had on the NHS?
I think if you only did it once, you can probably manage it. The problem with raiding the capital budget is when you do it too many years in a row, and particularly then attempting to manage capital spending down in NHS providers. For obvious reasons, you begin to build up a backlog of maintenance, and that begins to move into essential maintenance. So I think we've got two things now. One is effectively a hygiene issue for some providers, that they really need the money spent, and it's great having incentive schemes that try and support SDPs and ICS, but if your hospital's falling down, it's a pretty clear case you need to put some money into it. I think the other thing, particularly for the long term, we need a bit more confidence around where the capital spending is coming from, because at least some of the changes might need some investment at local level. That's particularly in developing community services. They're often quite light on capital. It's not necessarily a very big number, but it might be more than we've got at the moment. I think the Naylor review did point out that you could get this from more than one source. The taxpayer is one. But there are also some more innovative schemes about making the most of the NHS estate. So don't just sell it, knock it down and then build something really big that has a private sector tenant in it and use part of the building for the NHS. So I think a bit more imagination around the use of the NHS estate could also generate large sums of money.
I mean, I note from the figures we've got, I think there's an £800 million increase from 1819 to 1920 and a further 100 million from 1920 to 2021, which is good to see. So it is moving in the right direction. I mean, do you think there's a case for ring fencing that now the sort of backlog of maintenance and so on has got so significant? It's been an easy target, hasn't it, in previous years? Or?
The NHS can't just move capital money to revenue. It needs Treasury permission, so it's not something the NHS has done that you could then ring-fence. The capital budget is ring-fenced. The problem is the ring-fence keeps on moving. And so if government moves the ring-fence, the NHS makes the most of the money. I would like to think that increase is there, but if you look back over the last 5 years, at this point in the financial cycle, it was always there, and then it gets cut in year. And so it always looks like next year there's going to be a big increase in capital spending that, in fact, doesn't materialise, and it's not materialised now. So I think a bit more clarity that money is there and finding a way to commit to it. As I say, the capital budget is supposed to be ring-fenced as it is. It just hasn't really materialised.
So I don't quite understand that. I mean, for 18-19, we've got 5.9 billion of capital DEL spend. That goes up to 6.7 billion for 19-20. Are you saying that may not materialise?
So I think what they've done is shift money from in-year, if the day-to-day resource budget is under pressure. What the Treasury agrees to do to the Department of Health is take some of the money out of the capital budget and move it into the resource budget. And we are not confident that next year that won't happen again.
So that comes back to the ring fence, really, doesn't it? I mean, so you would be in favour of that, would you, given the backlogs?
Yeah, I think there's also worth thinking about as well, not just is the overall, can we protect the overall capital budget, but also very importantly, there is going to be there needs to be a capital plan to sit alongside and as part of the long-term plan. And I think there needs to be a serious look at the way we allocate capital and the priorities for investment in capital. So there is a clear issue around maintenance, obviously, but actually often the places that most need some of the capital investment often need relatively small-scale capital investment to unlock some improvements in the way care is delivered. So, give you an example, lots of clinicians will say to you that there are many services that at the moment are delivered in as day cases, which if outpatient departments were configured differently, they could do on an outpatient basis. You need some money to reconfigure the outpatient department, places that have access to the capital spending and not necessarily the places need. So they need to look fairly root and branch at how they allocate and prioritise capital.
What about sort of borrowing to invest? We've got some figures in our brief that the UK only has 9.5 CT scanners per million of population, compared with an EU 15 average of 24.1, and so too for MRI. MRIs, we've got 7.2 per million as opposed to 17.2 for the EU 15 average. I mean, if trusts were allowed to borrow to scale up, would there be a sort of efficiency payback in relation to their tariff payments? Or?
The challenge has always been borrow from who. So if you borrow from, attempt to get trusts borrowing from private banks want security. And never in the NHS has anyone been willing to give them the security that they need to lend in the first place. They can't come in and repossess NHS property. It's also struggled under PFI. The government can borrow quite cheaply. Trusts are effectively part of the public sector. They're borrowing scores against national spending, national debt. So it's been quite difficult not to use the publicly funded route. So yes, borrow to invest, but not necessarily make each trust do it on their own.
I mean, you mentioned PFI, which is what I'm going to come on to next, and I think, Anita, you've expressed some worries that the freeze on PFI could present some challenges to the capital budget, but I do note the annual repayments are around 2 billion a year, so PFI has come at quite a significant annual cost, doesn't it? When we were talking about a missing billion earlier, we could do quite a lot with 2 billion a year, couldn't we, to plug some of these holes? So, we've got lots of shiny buildings in the past, and we now have quite a significant annual price tag for them, don't we?
Yes, although I think it's quite... So there are some hospitals, undoubtedly, whose PFI arrangement is a major challenge for them. And NHS Improvement, I know Ian Dalton's here afterwards, have been trying to work quite hard through the finance regime to provide solutions to some of those providers. I mean, there are... This is not a very popular thing to say. There are good and bad PFIs, though. And not all of them are a problem for the NHS. I wouldn't argue necessarily that we should have a new big round of PFI or that the government's decision was wrong. I simply note that I think the capital plan was predicated on that, so we do have to come up with an alternative. I think Richard's point, which he made earlier on, can't be stated too much. We also the NHS being pushed to sell estate, and I firmly think that the bigger issue is poor utilisation of estate, and it's not clear that selling estate is always optimal. I used to be board of an NHS trust, and we were in fairly central to central London, and if you wanted to know what buildings we owned, you just had to walk around, and we were the only single-storey building in our zone, and actually things like Rich was saying, where you redevelop that, and there are links here as well to things like, which people have been talking about, using that asset base much better for things like house accommodation for staff as well. And so we do need a much more imaginative approach to capital.
We're going to need those sort of innovative approaches to
absolutely we are. But it's very difficult at the moment for individual NHS boards, the expertise you need, the timelines you need to do these sort of things are not easily available. So how we get the capacity and capability to be really good at managing our estate.
You mentioned the Naylor review earlier, and I remember during the general election last year there was some political controversy around Naylor, wasn't it? But I mean, what you're suggesting sounds quite sensible. I mean, this is all money that comes back into the NHS. It's just an extra revenue stream from existing public estate, with the income coming back into the health service. I mean, you wouldn't see that as politically contentious?
Sensible as long as the Treasury agrees this is additional cash. What you don't, so one of the reasons why, one of the reasons, there's lots of other reasons, one of the reasons why it doesn't exist already is because at the moment, if the NHS did start earning substantial income stream from this estate, the Treasury would turn around 2 years later and say, OK, we take that off what we give you. Because after all, it's trying to save the taxpayer money. So one of the ways to incentivise it would be to ensure that is actually additional cash. And I don't know how you sort of hardwire that into Treasury thinking.
We come on then to Johnny and mental health.
Can I just talk about mental health briefly? So this government's obviously committed to parity of esteem for physical and mental health spending. And, one of the ways they say they're doing this is increasing, by the amount they're increasing in physical health expenditure, they're increasing in mental health expenditure. I mean, do you think this is a good way of sort of measuring mental health services? And if not, what's a better way of doing so?
I was around in the system as we brought in 18 weeks and the 4-hour target. You didn't ask providers how much money they'd spent on it. You asked them had they done it. I think in mental health, we don't have a reasonable, broad-based measure of a good quality service. Without that, we fall back onto trying to measure the money. And so you could put more money in and find it was poorly spent.
Qualitative marking system.
I think they're harder. It's hard. Mental health is a long-term condition. It involves very different degrees of severity of illness. I don't think it's impossible. I just think it's much more complicated. And instead of doing it, it's never, I think, been given the attention it needs to try and sort out how we'd measure what is good and what is bad. And I think it was done a bit under the National Service Framework with big central budgets and a lot of experts running the system. And you can do it that way. It's not really the way that we do things these days. Without it, measuring the money is a kind of second best. So I wouldn't say stop doing it, but you have to realise that it doesn't really say, are the costs in mental health going up quicker? What would be the right number for mental health? If you've cut mental health for the last 4 years, perhaps it should be faster than the money going in.
In communities like mine in Plymouth, if you want to judge how mental health service is doing, and you start talking about how much money you're putting into it, it kind of makes the situation a little bit worse for the mental health community, because they feel, actually, you say you're putting this in, but the way it feels for me, trying to get increased access to psychological therapies for my schizophrenic son or whatever it may be, it doesn't feel that way. So how do we find a measure in the middle that we can actually hold the government to account in how far along this journey of parity of esteem that it's actually got?
I think you could use a series of measures of access to psychological therapies. What you absolutely need alongside that is a robust measure, which I don't think is impossible to do for acute mental illness. I think one of the problems with investing more in psychological therapies, which is a very good thing to do, is that the service did it by pinching money off of other parts of mental health, and it recycled money within the system. It didn't genuinely put in more money into the service, and you can see it through the workforce numbers that they've tended to go down stable now. As I say, could I name what those outcome measures are at the moment? No, I could name some of them. We know things about out-of-area transfers. We know things about access to psychological therapies.
A tangible, measurable output, isn't it? If people are going 600 miles from Plymouth to Leeds to get access to a mental health treatment, then clearly that is unacceptable. I mean, Anita, what would you say?
Well, so two things. I think it is important to challenge the department on the priority it attaches to putting in place proper measures. Because actually, as Rich points out, when the 18-week target was first introduced, we could not measure it. We didn't have measures all along the pathway, and they had to be created. And the establishment of the target was one of the things that led a push to much better measures of how long. We knew how many people were on the waiting list. We did not know. We knew bits of the pathway, how long they might be waiting from this bit to this bit, but actually a meaningful measure of their waiting time was not available. So part of this is another reflection of our priorities. We just haven't made really tracking what is important to people in mental health a priority. In the medium term, I mean, when I look through for the money, I can't track it all through the system. I can't see where all the money has gone on mental health. I do think, though, the thing that will be most important for actually really improving quality of care is the workforce, is having the people there. And so in the medium term, I would put most effort into tracking the mental health workforce, because if there are workers, you can deliver.
I mean, there is one way of measuring this, which is that when a young person reports to their GP with mental health problems, there is a way of measuring then how long they have to wait for their first contact with the mental health system. Why are we not measuring that as a terms of, viable outcomes?
I don't know why we're not measuring it. I think it's a great thing to do. More measures of mental health are better. Do make sure the resourcing is there behind it, because if the resourcing isn't there...
You follow the data, right? Yeah. I mean, this is really basic stuff. I've literally just thought of that, right? This is really basic stuff.
It is, as Anita said, as long as the staff are there. If you push the service into trying to game the target, they will ultimately do it. And we know in some areas of mental health, including in children, that if you miss an appointment, they'll kick you right off the list and send you to the back again. And so there are ways to game targets. It's one of the problems with them. They're not a be-all and end-all. But absolutely, I think
right. Ultimately, we're the ones who go out in the doors and get a hard time for there not being mental health service. Don't get me wrong. The people who really suffer in this are the users, right? But we get held to account for it as well. And if there is something tangible there, like waiting times, we can, the government, rightly so, will say we're putting more money into this. But if they're not meeting targets, then it gives us an insight to how to do that. And I don't understand why, you have cancer waiting times. Why do you not have that's really basic stuff. Why do you not have mental health waiting times?
Indeed, and IAPT were trying to develop, whether they do exist. The bit that we're missing is particularly around some of the more acute mental health conditions, okay. and I think they should be there.
Sally, have you got anything to add?
I'll add one of my colleagues there.
Okay, and what do you think of ring-fencing mental health spending? So Simon Stevens has come in here and says, I don't want to ring-fence mental health spending because it's ultimately going to be detrimental to what we're trying to do. There are others who think we should, and people like me are fairly agnostic in the middle. What's your view?
I think it is. So I'm torn between this. So I think the introduction of the IAPT programme almost certainly only made the progress it did by being ring-fenced very tightly and centrally driven. I think if that hadn't happened, there would have been change, but would there have been the same scale of change? Against that is, the whole one of the whole things that obviously is so important in the debate about mental health is that we're not wanting to see mental health as a separate, disconnected service. We're wanting to integrate mental health services with physical health so that we look at people as a whole and we treat all of their conditions as a whole. So if we're wanting to have workers who think about the physical health of patients who appear to have presented with mental health problems, but equally for people with long-term conditions who often then have a mental health problem as physical long-term conditions, we want them treated in an integrated way. So one of the risks with ring fencing is it moves back that agenda. I think there are probably ways, if you really pushed to measure activity, outcomes and workforce properly, where you can achieve many of the objectives of ring fencing without the downside of ring fencing, but it means that you need really concerted action on all of those things and absolute transparency about it. And I'd commend to you an NAO report on mental health, which shows how far we've got to go on all of that.
Probably the same place. My experience of ring fencing, if you're doing it in the NHS, is it can be a charter for accountants. And you'll get endless battles over which side of the line does this spending fall. Is it really health? Is it really mental health? Is it really social care? I get that broad measure of the resources that are going in, which is particularly workforce. And remember, in mental health, the workforce is much higher share of overall spending than it is in acute services. A measure of access and a measure of outcomes, and that would be better than trying to invest in a really detailed system of ring fencing.
Yeah. Okay, thank you.
Thank you. Final section, I just wanted to ask you a bit more about workforce, and I know Richard Kingspan has done quite a lot on this and commented that it's actually the workforce crisis that is more pressing than the financial crisis, if anything. When we're looking at the long-term plan and the money that's being invested from the budget, how do you feel we can best spend it in terms of the workforce? Should we be focusing on retention or recruitment? Where do you feel that the real gap is?
So I should quickly say that my colleagues from the other two foundations think exactly the same that we do. So it was actually a joint statement that workforce is the key issue. I wouldn't pull one lever. I think we're in such a state on the workforce, particularly as more money comes into the system. You need to pull all of them at the same time. And that shouldn't be beyond the system to do. It has done it before, so it will be looking at training. Admittedly, that's a fairly long-term play. Recruitment, why are so many people that qualify don't show up in either the NHS or in private healthcare services with a job? Retention, what we can do with skill mix. Not every profession is in shortage. We know, thinking particularly about primary care, there are pharmacists, there are physiotherapists that we could use to take up some of the burden, absolutely within their skill set, and be ready to do international recruitment. And many people don't like the international recruitment side, but if you want to do something quick, to take some of the pressure off of existing staff to try and get their workloads back to be manageable again, which I think will be truly key in retention, be ready to use the international lever in a way that we haven't done for a while.
Concerned about the Prime Minister's comments the other day that were about international recruitment and immigration. I mean, clearly, if you can't recruit from the EU so easily, you're adding huge bureaucratic costs. If you're because at the moment there are relatively few bureaucratic costs to recruiting from the EU. What's going to be the impact on the total costs for the NHS if those are increased following Britain leaving the European Union?
I think if we carry on with the system we've got at the present, so each individual organisation has a go at international recruitment by itself, largely. There are one or two exceptions where that's not what we do. You'll find they just won't do it. It's just too expensive. It's difficult showing up in New Delhi or Manila to try and recruit staff. It's not an easy thing for each individual organisation to do. So I fear the worst possible outcome is that it will choke off a lot of the potential supply that the United Kingdom could still get. And so finding an easy way through, both through the existing system of migration rules, immigration rules and visas, being clear with the professional regulators how they handle some of the migrants coming in, and helping NHS employers do it. I think expecting each individual organisation largely to have a go at it themselves is not the way to bring in people. Centrally supported, could be regionally run. We know, Andrew Foster in the north of England runs it on a bigger footprint and is very successful at bringing in staff and has the expertise and the kind of the resource to be able to do it. It's not easy, but you can bring in people quite quickly.
Looking at the extra costs, not just in terms of financial but bureaucratic costs, could you give us an idea of how much more expensive it is to recruit somebody from outside the European Union than it currently is within the European Union? What that will add if all those current EU staff in future have to go through those bureaucratic hurdles? Can you give us an idea
we'd
of how
have to
much
look.
extra
I think we
cost?
have a number for the average cost. What I don't have is the breakdown. We'd have to write to you with that. Yeah.
So I find that very helpful because it is a concern, not just, as you say, the issue of actually physically getting out there and doing it, but what the extra bureaucracy is, and also the issue around the £30,000 threshold.
Work.
Certainly for social care staff. Can I bring Sally and perhaps in and Anita on this?
Anita, you're a co-author of the report.
Yeah. So I think obviously an awful lot of the staff that we have at the moment in both NHS and social care would not be earning £30,000 on arrival, and it isn't the case in the NHS that that pay exactly maps to skills shortages. Which is kind of the underlying ethos here. We have some key skill shortages below £30,000. So that threshold would undoubtedly be problematic. I think the one thing I'd add to what Richard said is that beyond the individual measures, which are really important, one of the things that is clear here is I think that for at least the next decade, and I've struggled to think of a scenario for health and social care where this isn't true, we are going to have to be incredibly good at workforce planning and workforce deployment and strategy at the national level and locally. And our system for doing that, our capability and skills and capacity is nowhere near strong enough at any level of the system. And so I think clearly the long-term plan needs to think about individual policy areas and coherence there within the workforce, but also it needs to look across the system at how we manage this absolutely vital area of health service policy and delivery.
Yes, and obviously the impact on the HE budget will be significant if that is cut to top up NHS England. Paul, you had a...
Yeah, it was on the topic of recruitment, maybe international recruitment. You talked about NHS providers, but I presume you weren't really talking about general practice. Of course, there was a plan to bring in 5,000 extra GPs. I just wondered if you wanted to reflect on that as well.
I think you could bring in 5,000 GPs if you made the timescale incredibly long. So I think it's turning out to be very difficult to bring in large numbers of GPs. Partly we're targeting countries where I don't think their GPs frankly wish to come here. And GPs, particularly where they're more nested in the community, your English language skills frankly have to be very high, and there's something about cultural understanding of the people that you're working with. And I mean, it's completely unfair, but for some surgeons they don't quite need as much of those communication skills. So I think we need people are leaving general practice, so the inflow isn't too bad at the moment, but people are leaving. The workload appears to have got too difficult. So even if the international recruitment lever is harder to pull, I think, in general practice than it is in some other areas, there are other professions in primary care that you could use quite quickly. A large part of, even now, GP's workload is on medicines. Some of that can go to pharmacists. About 20% of GP's workload is on musculoskeletal, and some of that can go to physiotherapists. Fortunately for us, these are large professions that are not quite as in such short supply. And you're absolutely right. You really need to get the GP that workforce modelling correct. The slight danger with looking to NHS providers, of course, they won't look at primary care. That just isn't in scope. And so if they don't, you need to know who will.
Well, thank you very much for coming this afternoon. Really appreciate it. For being patient with us. For those following from outside the room, could I ask you to introduce yourselves and who you're representing? And I'll start, shall I, with yourself, Ian Dalton.
Thank you. Ian Dalton, Chief Exec of NHS Improvement.
Hi, I'm Jeanelle Gruchy. I'm Director of Public Health in Tameside in Greater Manchester, and I'm President of the Association of Directors of Public Health.
Hello, good afternoon. My name's Glen, Garrod. My title for the national role is President of the Association of Directors of Adult Social Services. My day job is responsibility for social care and public health in Lincolnshire.
Much. And Ben Bradshaw is going to open the question.
Yes. Can I ask all of you, the government has chosen to focus increased funding on NHS England. Do you think there's a case that it would be better to use some of that extra funding for public health and social care instead?
myself, yes. Yes, I think is the short answer. We certainly welcome the increased funding to the NHS. I think you've heard colleagues before the previous panel talk about the importance of the funding to the NHS, but that unfortunately public health has, through public health delivered through local government and through directors of public health, has had to cope with an immense amount of cuts, £700 million worth of cuts since 1415 to 1920, which is a large amount of money. And those are a large number of services we fund and commission are actually NHS services, which I don't think was brought out earlier. So there's also this kind of slight double speak about it, because those are the sexual health services or health visiting services, drug services and so on. Those are NHS services that are, our grant is funding. And those are being cut. I mean, so I think we definitely feel, the previous panel talked about the real cost effectiveness of public health services, and there's no logical reason to cut the grant, particularly at the same time as talking about the importance of prevention.
Okay, I'm going to take a slightly different tack to Jeanelle. Some of my best lines have already been used by the previous panel members, but I'll have a go at something extra. From a social care perspective, I think the narrative is a little unfortunate. In a local system, we shouldn't be having the discussions which says this is an NHS budget, this is a social care budget, this is a public health budget. Most of the people increasingly that we see nowadays have complex needs. They don't just have a social care need or a health need. And in some respects, that also mirrors the debate about mental health. So for social care, it deserves its own space. It deserves its own relevance in better meeting people's needs. I think if we are to rob Peter to pay Paul, we go nowhere. And again, from a social care perspective, as we've heard, the NHS isn't getting what it felt it needed. In fact, it's probably far less than it felt it needed in the first place. But I do feel that how it spends that money and how the money is distributed and used is critical to our future success if we're to leave a better legacy than, frankly, the one that we've got. My main point is to reference Sir Derek Wanless in 2002, when he said, unless we spend more on prevention and community, bad things will happen. Bad things are happening. The public narrative doesn't necessarily reflect just how bad things are in local systems. But if Simon, Stevens and Ian do not spend the extra funds, however short of ideal, on primary and community, with more community nurses, more GPs, more prevention, then we'll be back here again in a few years' time saying things are getting worse.
Your colleagues on this?
Yes and no. I think what's clear is that the NHS has come through a very difficult period in its history where the rising budget each year for the NHS has been at a lower level than it has been used to, and that has manifested itself in financial pressure across the system. So I think I disagree with Jeanelle that there's an argument that within the 3.4% settlement that has been granted by the government to the NHS for the next 5 years, there is scope to take some of that 3.4%, which is going to be very important for ensuring that we can look after an ageing population in hospital and in the community and in primary care, and giving that to other budgets. But the yes element of this is that for the NHS to be successful in looking after people, the NHS doesn't exist in a bubble, and our 3.4% is also dependent upon an appropriate set of investments. I'm sure we'll talk about it today, in public health and prevention, which I very strongly support. If we think about things like smoking cessation, for instance, these will be the patients of tomorrow, and therefore getting upstream on that's important. You've had an extensive discussion about workforce and the budget for training members of staff so that we can generate over the period of the long-term plan, move from a deficit in staffing to a balance between supply and demand over that period is really important. If I look at the capital budget, well, again, we'll be talking about that, I'm sure. The capital budget is also important. So I think I wouldn't accept that the 3.4% allows us to take money away from the NHS and put it into these other areas, but I would absolutely accept that these areas, and absolutely social care as well, are critical for the success of the NHS over the next period.
Can I ask you about the impact this is having on NHS performance? Because at last autumn's budget, we were promised that significant inroads would be made into waiting times, and the NHS plan this February said that waiting lists in March 2019 would not be higher than March 2018, when they're about 3.8 million, and the number of people waiting 52 weeks would be halved from 2,755 to 1,378. Well, I have to say now the current total waiting people on the waiting list is 4.1 million, so it's gone up, not down. And the number waiting more than 52 weeks has also gone up to 3,150. So all of these indicators are going in the wrong direction. I mean, the promises that were made about waiting times have been proved completely worthless, haven't they?
2 points. I think the first thing, and this is where I suspect all three of us on this panel will agree, and the long-term plan will need to deal with this, what we're seeing is a continued rise in demand from urgent and emergency patients coming into our hospital. We've had that for several years now. That is having a continued effect of displacing within the hospital capacity care for patients that are clinically less urgent. It's the right thing to see in a more urgent patient. But within the capacity we have, inevitably that has to be prioritised. And so I think you will see, we haven't yet published our Q2 report, which will show the latest figures, but I can take you back to the Q1 report or the Q4 report in the year before that, and I've talked to this committee before. We're seeing a long-term rise in hospitalisation from an ageing population, typically coming in as urgent and emergency cases. And necessarily that has an impact on elective waiting times. The plan needs to be able to address the demands of urgent and emergency care patients, and also needs to be able to address the legitimate demands about people who need elective surgery. Nobody in the NHS is comfortable about patients waiting longer than they have to for elective surgery. We all want to treat patients quickly, but to do that, we absolutely have to invest our money over the next few years in both new capacity and in new ways in the community, particularly of looking after frail older people.
Why make these promises when they're just not going to be... It's pretty clear to us at the time they weren't going to be met, and it's now absolutely clear they're not to be met. What is the point of ministers and officials coming to this committee making these bold promises which are totally worthless? It damages the public's credibility in our whole system.
Well, I think I would suggest, certainly say in relation to 52-week waiters, that we expect to see those numbers reduce by March, and we're pushing hard for that. Clearly we've got a winter to deal with, but that would be an objective. Our aim is to treat every single elective patient we can within the capacity, but I think it is inevitable that, and I'm sure the committee will understand, that the rise in emergency demand has to be met first.
Mr. Garrod, can you give us some examples of some of the difficult decisions that directors of social care are having to make at local level to deal with the current situation that they're facing?
Yes, thank you for the question. In fact, in September, we conducted a national survey of my colleagues. The results from that survey are quite clear, which is the concentration on delayed transfers of care has had a direct effect on A&E admissions for non-electives, unnecessary admissions to hospital. It has also had a material effect on the number of people entering residential care and not then going back home. I personally feel that's a moral issue. It's also something that the Competition and Markets Authority and the King's Fund and the National Audit Office have also commented on. In addition to that, though, what isn't happening in the community isn't where the public narrative or the policy rhetoric is taking us. The public narrative is all around performance on detox. Yet I have colleagues in this country who've got a waiting list for assessments of new people over 4 figures. I've got people waiting months. There are 125,000 people not receiving an assessment for deprivation of liberty. And I won't tell you just how bad level of provision is, but we also have people getting smaller packages of care that aren't truly getting to where it's needed. And as Age UK have rightly said, there are some 1.4 million people with an unmet need for social care. Some of the consequences are clearly having an effect, not on the back door of hospitals, because our performance there is good and has got better. What's really happening, though, is that the front door of A&E is now facing crisis. Not too long ago, I sat at an A&E on a Monday afternoon with an acute trust chief executive and counted the people who shouldn't have been there because there weren't GPs, there weren't community hospitals, and there wasn't social care in the community. We're looking at the wrong end of the telescope in dealing with something that's far bigger, and the narrative just isn't there for that at the moment.
Diana.
Well, I'd like to move on to public health. So these are mainly questions, Jeanelle, for you. First of all, what effect do you expect the funding for public health to have on the ability of the NHS to spend its uplift over the next few years effectively?
Thanks. If I can just clarify my previous comments as well, it wasn't wanting the NHS uplift, it was more the concern that was raised at the previous panel about the pensions and the potential further cuts. But I think it also relates, to your question about how, and Glen, it's local systems, isn't it? I mean, at a local level, these systems all interconnect, and we need to see people in a place. People live in places, and there's a lot that how we live our lives that is being impacted in terms of austerity or cuts more generally. And that does help. That it's about how we create healthy places and healthy people and healthy society. And I think the point again was made earlier about if we just focus on the National Health Service, we're missing a trick in terms of health and the health of people and our local populations. And as a director of population health or public health, that's what I have responsibility for. And so equally, while I'm concerned about the public health grant being reduced, I'm also really concerned about local government funding being reduced more generally, because it's in all those other services, whether it's we're looking at leisure services or youth services, schools are impacted, our ability to support healthy workforces, initiatives and so on. Those are all having an impact in terms of health. And we're particularly concerned also about children. And I know we've got looking at adult social care here and the impact on the NHS. But, if we really are serious about prevention, it's from the very, it's preconception, but from those early years that we need to be ensuring that we support the best start in life so that we prevent all these issues later on. So I'm not sure did I...
So perhaps you could tell us a little bit more about what the preventative strategies are that you think need to be in place to then have an impact.
So I think, again, going back to local systems, local places, directors of public health are well placed. We're in local government, but we're generally very familiar. I mean, I was a doctor in the NHS, so we're familiar with NHS. Our services, and we can see across the system. Now, some of what we need to tackle some of the tricky public health issues of today are services. So take smoking, tobacco, and the real impact on the NHS. So smoking cessation services, of course, and we fund some of those. We've modernised, we've transformed the way in which we're providing that. We're targeting the most hard to reach. We're targeting people with mental health issues who we know have got very high smoking levels and poor healthy life expectancy as a consequence. So there's those services, but then we also know there's policies. The smoke-free workplace legislation that needs enforcement. That needs our teams to go out and work with those doing illicit tobacco. So there's lots of work. There's responsible retailing, so we don't sell to underage children, not selling to children. There's local smoke-free places that we talk to. We talk to our local politicians about having those. And then it's about getting the community. Who and how do we get communities engaged with smoke-free places? How do we raise the importance of smoking? Because now, certain communities, particularly in more deprived areas, are smoking. There's still quite a high proportion of people smoking, whereas in other more affluent communities, you actually hardly see it anymore. But who raises that inequality issue? I think that's our job, but we do that across with partners. Now, when you have the carts, if you say, well, what's the impact of the cart? It's both to services, like smoking cessation service, but actually it's also to us and our expertise, either advising the NHS around smoking cessation services and support, or our expertise across local systems to see where is the evidence best, how does it support the reduction of smoking in a place. And that's, I think, it's really hard to characterise, but that's our role, and you can see that read across a whole range of public health issues where we're working locally.
When the Secretary of State came to the committee earlier this year, I asked him about public health spend, and he told me that there were very good examples of where, despite the cuts, there was excellent work going on in terms of public health. And he said he'd write to me with details of where these areas were. Unfortunately, I've not had any details of where these areas are, but I just wondered whether you might be able to highlight for me, where do you think, despite the cuts, there's really good public health work going on that you can point to and say that's going to have an impact as we move on down the years?
I think there are quite a number, and certainly we will provide the committee. We can provide that written support. I think we are, a large proportion of our budget is going on to certain public health services. So that's the health visiting service, the drug and alcohol, or particularly drug service, and sexual health services. And I think there are numerous examples where we've, despite large cuts, transformed the way we've brought about delivering those services. We've had to. So whether it's shifted, and at the same time, some of those treatment services shifted more towards prevention. We've had to make those services more accessible. So we've been looking at digital. We've been innovating around digital. We've been looking at skill mix around health visiting. Perhaps there's other skill mix that can help deliver those services because of recruitment issues there. We've had to innovate in all sorts of ways because we've had to deal with the cuts of those services. But I think our members are certainly getting to the point where we've done that, we've innovated, the cuts are real. As I said, a large proportion are NHS services that have reduced, and I think we now will start to see a real reduction, potentially, in health visiting services, in sexual health services, in drug services, with consequent impact. Drug services already mentioned police and crime and the impact on there. Health visiting, you can imagine what the consequence over time in terms of prevention. And sexual health as well. We've had to transform our services and deal with cuts whilst the demand has gone up. So I do think, though, that despite all of that, there are some very, very good examples where we're trying to provide that system leadership, working through the NHS, working with the NHS, social prescribing, supporting yourselves. But it's how does the money flow and how does our expertise support the NHS to spend that money well? because I think that's another key message. I think the money that is going for prevention to the NHS, Directors of Public Health and our teams have the expertise to help look at what the evidence is, look at what the evidence base is, and spend and commission those services, whether it's from the voluntary sector or elsewhere, that we can help spend that money well.
Can I just ask you about public health budgets and local government in particular, because you said you've got the overview of what's going on and where the money's being spent, and I just wondered, there's always been a concern that public health budgets may be used for spending on things that are not strictly public health, and I just wondered whether you thought that was the case and whether money was being diverted into types of activity that are not traditionally seen as public health but might have a public health benefit.
I think we, as I said before, local government has a major role in terms of creating healthy places, and that is, I think, a really undersold but really, really important role for local government. And as you know, councils are experiencing severe cuts to how they can provide healthy places for people. I think also we've heard about adult social care, the same in pressures on adult social care, the same with children's social care. And what we've been trying to do, working closely with our Directors of Children's Services, Director of Adult Services, is collectively, together, how do we shift from that high-end, high need for adult social care or children's social care to more prevention. Now, our services and our funding is contributing to that wider piece. I think there is a real challenge, though, for councils to balance the budget. That is a lot that we're trying to do given the large-scale cuts. I think it is a challenge. It's a tension, and I think it will continue to be so. And the concern that's already been raised here about potential further cuts to the public health grant, I think we will really, really struggle in terms of that, both public health but also the councils, to meet those further cuts if there are any.
Paul wants to come in.
Yeah, just come in on this. I just don't understand the logic here. Why cut sexual health services but not cut gynaecology? What's the logic in cutting health visiting but not cutting midwifery? Why are we cutting substance misuse services whilst investing in mental health services? What's the logic here?
So I don't think there is any logic. I think those services, I think Directors of Public Health need to be in local government because of all the other reasons I talked about, providing that local system leadership. Those services, are commissioned by ourselves. I think I think that's worked really, really well in terms of, our ability to commission those services and commission them well. The difficulty is this false boundary, organisational boundary, isn't it? And I think that's really imbalancing the system. So what we want is proper local systems working really well, but we've got an imbalance, and I think we're going to see an increasing imbalance. And you're right, it doesn't make any sense. And there's a distortion of how we create healthy places and healthy populations.
Can you this?
What is clear, I think, is that there is real benefit to people in places from expenditure through the public health grant, and that isn't an argument to take money off the NHS. That's the Peter and Paul argument, which I think doesn't really stack up, but it certainly benefits the health service as well as the people in communities to have the areas of expenditure we've talked about at an appropriate level. The future in the long-term plan, I think, will be very much about what takes place in places, and that absolutely means that we have to be there with the right model of acute and community and primary health care to cope with people's health needs. But of course, there's real merit in making sure that the population's health is good and that we prevent people from getting diseases that otherwise we will have to treat in the future. And smoking cessation, for instance, we know that today's smokers will end up as patients and will need to be treated. If we can prevent people becoming patients because they give up cigarettes, then clearly that's an advantage for the people themselves, but also for the health service. So I don't think it's an either-or. I'm actually very supportive, though.
Because patients don't care what the funding route or the commissioning route is here. They don't know. They don't even know that the funding. Most people that when they've got a something that's categorised as a sexual health problem, it's funded in one direction, and something that's categorised as a gynecological problem is funded in a different direction.
I'm not arguing with that. I suppose the point I made right at the top of this discussion is I think the settlement of the 3.4% real is going to be needed to support the change we need to see in the NHS. That doesn't in any way undermine the importance of social care or public health.
I want to come on to capital, but just before I do, it's a question really for Glen and Jeanelle. I mean, I get all the points that Dr. Williams and others have been making about public health. It does strike me, though, that local government does have a huge opportunity to design healthy environments. We're building a lot of new housing estates. They could all have cycleways and walking paths to school. We build new roads. We could have decent cycle and pedestrian lanes. Some local authorities, Canterbury, I just happened to see recently, coming out with really good clean air strategies. All these takeaways next to schools and so on. All councils have planning powers. So the money is one side of life, and I absolutely get that. But it strikes me is that you are quite sort of underpowered, frankly, in sort of seizing the initiative to really, design health into the new environments with the new housing and the new roads. You probably share my frustration. What do we need to do to achieve that?
Thank you. Frustration seems to be a central feature of my emotional state most times at the present. So there's something about coherence across national policies, if you'll forgive me for pushing back a little. I've worked in the sector for 35 years. I've yet to see a coherent set of national policies that push in the same direction as experienced in local systems. And you've given a good example there between health and public health. Of course, some of the councils that are doing something remarkably good, despite the austerity that they're facing, have recognised the contributory elements of all the things that they have at their disposal. Housing is a key one. We haven't talked about housing, but it's critical if we're to better meet people's needs. And it's also critical if we're to better meet the NHS's requirements. And yet it hasn't really featured on the landscape in any major way. I take the point about housing, but there are some policy drives that take us in the wrong direction around some of that. The Chancellor's announcement of 55 million for disabled facilities grants to be spent within the year in two-tier areas just doesn't work and won't necessarily help health and social care systems. And yet it could. New house building design standards, another opportunity. Leisure services, the opportunity for digital innovation, both across health and social care. And it's interesting that one of Jeanelle's colleagues in Wigan told me a few months ago she doesn't have a public health budget. It's distributed across the council. Why? Because it adds to the other pots that might be shaped towards more preventative approaches. If we just see public health in a preventative bubble and nobody else does it, frankly, that's a missed opportunity. By the same token, I think we've also got to recognise that just under 40% of councils' budgets have been cut in the last 8 years. A lot of that has been the back office functions, the things that might have led to more creative thinking. By the same token, borrowing 10 million on a council's budget costs you 1 million to serve the debt. Sorry, 10 million costs 1 million to serve the debt. Not many councils can afford a high borrowing ratio, given what's happening to their revenue spends. It's just a really difficult situation to be in, and we can't just talk to DHSC. If MHCLG isn't part of this equation as well, because they're funding some of the things that could make the difference.
Yeah, and I'd reinforce that. It goes back to how do we create healthy places, and essentially we won't be able to treat our way out of the NHS crisis. We've got to create a healthier population, and to do that we've got to get people walking, cycling, eating better, not being lonely. And some of the new housing developments you see where they built for motorway access only, or there was a report recently on that. What kind of communities are we creating? What kind of societies? But I do think that certainly echo Glen. There's some really, really good innovative work happening at local levels to try and join that up, to try and use the levers that we have. But if you cut accounts by 40%, the wiggle room you have to innovate, or certainly public health expertise you have around the evidence base, ability to influence a wide range of partners to create healthier places is more limited than it can be. So I guess my pushback is, if we were adequately resourced, Health Foundation says 3.2 billion for public health per year. If we got that adequate resource, wow, what could we be doing?
I want to move on to capital now. So, Ian, these are sort of a series of questions for you, if I may. The maintenance backlog, I think, is 6 billion, having gone up from 5.5 billion last year. Are we going to stop seeing capital budgets raided in order to deal with that?
Ideally, and certainly I would hope yes, but I think we need to take a step back if we can. I mean, there's a significant capital issue that needs to be addressed over the next period of the NHS's history. We spend, I think, about 3.1% of total health expenditure on capital. That's compared to an OECD average across 34 countries of 5.6. So while it's great that we spend more than other large countries like Greece, Mexico and the Russian Federation, we're spending less than Sweden, France and Germany. I think in relation to the specific point, we've, as an NHS, effectively had to depress capital expenditure over the last 5 years to balance the books. And one of the things that needs to change when we see what's in the spending review, and I think I've talked to this committee before about the importance of opening the taps on capital to support not only the backlog, and I'll get to that in a minute because it's a big issue, but it's by no means the only issue, but also the building of new facilities, both in hospital and, frankly, in the community. On the backlog specifically, we have seen over the years, looking at significant and high, which is probably better than the total, an increase from 13-14 of 1,374 million. That's gone up to 3 billion and 77. So it's gone up from 1.374 billion to nearly 3.1
so
billion.
This is the highest need of...
This is the significant and high, the top two categories, which are the ones that backlog, therefore have built up most rapidly over the last couple of years.
That's backlog, so
No, spending is a different issue. The two most, the demand effectively over the years since 13-14 to 2017-18 for significant and high, as we categorise it, has gone up from just under 1.4 billion to coming close to 3.1 billion.
About the impact of the sort of backlog. So, to what extent are sort of poorly maintained buildings and the lack of equipment? I gave the comparative figures on CT and MRI scanners a moment ago. So, to what extent is the lack of equipment and some of the poor maintenance you've talked about holding back productivity and efficiency? What sort of gains would there be if we could make up that?
The answer is there are obviously disbenefits to the NHS and doctor staff working in it and patients from having buildings with high levels of maintenance problem. If a lift breaks down, for instance, because it needs replacing, and that lift is meant to take a patient to theatre, the physical act of getting the patient from the ward to the theatre becomes more difficult, and the number of patients that can be then treated becomes more difficult. So the reality is we do have a need for a significant capital injection through the spending review. Obviously, we don't know over the next 5 years, and preferably beyond, what the capital settlement for the NHS is. I'm hoping that we can have a longer-term capital settlement, because by definition, investing in capital, whether it's sorting out the highest priority backlog, let alone building the new facilities, some of which are in the community, some of which are new hospitals, that we're going to need to deal with the population over the next 5 and 10 years, is a long-term game, and so doesn't lend itself to short-term injections of capital.
Can I just focus on the equipment for a moment? So to what extent is the lower ratio of MRI and CT scanners causing a sort of pinch point within the process of...
We'll see over the next few years is a very significant rise in demand for diagnostic tests. And as we improve cancer services, there'll be more patients who will need to be scanned. Most of them will not have cancer, but it's still important that they do. So it is absolutely true that we need the right number of machines, and they need to be scaled to the demand that is going to continue to increase.
Right, but I mean, just coming back to the numbers, our 9.5 CT scanners per million compared with an EU average of 24.1, that is a huge difference. So how serious an issue is it to you and your top team that our numbers are so far out? I mean, do the E15 just have too many that get wasted? I mean, are we really efficient with the ones we've got? Or are we being held back? I'm not getting any sense from you at all. I mean, this is a big disparity, but I don't get a sense from you yet as to what your view on that disparity is.
My view on the disparity, I mean, I don't have a numerical view on the distinction between us and Europe, though we could provide that if necessary. I think what I'm clear about, though, is we're going to need newer machines, and we're going to need more of them going forward, because the demand coming through is rising for diagnostics particularly fast, and the waiting times are getting longer. So there's a need for really significant improvement in diagnostics. Part of that is about staffing. We might talk about that. Part of it is about machines and making sure that those machines are well used.
Is there no part of NHSI that looks at international comparators to see how the NHS is doing in terms of capital?
We do that. I think more importantly, and this is where the long-term plan will set its stall out, it's what we need to cope with our population's need over the next 5 and 10 years. And I think, as I've said, we're going to need to see a very significant increase in access to diagnostics. And that will mean more machines.
My question, with respect, my question is, what capacity do you have? I mean, I think this is a government-wide problem, so if you don't have it, you're not alone in Whitehall. I can give you that comfort. But it would just strike me that it would be useful to know what other countries were doing well, and if this extra number of machines, were making a serious difference to their efficiency. I mean, I won't labour the point, but I think it's perhaps something to take back to Baroness Harding, in your next conversation with her. So, just in terms of, you talked about opening the taps. You were quoted as saying that when you came to see us in July. The changes to PFI,
yes,
were obviously, I don't know if they came as a surprise to you within the budget. The NHS providers, I think, have told us that they think that some trusts with onerous PFI contracts will need further financial support in the future. What's the extent of that sort of further financial support? Is that an area that you're focused on, aware of? Is that a particular concern to you? Are you going to be plugging these PFI annual costs for some time to come in order to help trusts do what they need to do?
I think as one of the previous speakers said, there are PFI deals and PFI deals. The total unitary charge cost to the NHS is £1.9 billion, was last year. That's managed across 50 different organisations. And the impact on those organisations is actually pretty differential. One of the things that we have to do over the next 5 years, and we haven't finalised how we do this yet, is to have a look at the relatively small number of organisations that have a very high PFI cost that is going to make it more difficult for them to balance the books. At the moment, as you know, for reasons that have been rehearsed in this committee before, the vast bulk of hospitals are in deficit, and over the next 5 years they need to balance the books. There will be some relatively small number that will have to have a particular look at the PFI, and so that's an ongoing conversation. I think the other issue, of course, is how the non-use of PFI and PF2 over the next period, the £3 billion that was meant to come from that is going to be replaced, because obviously the importance the NHS attaches to that is if it's not coming through PFI, we need to see that replaced as part of the settlement.
A final question from me on this section. I have a memory that a few years ago there was a degree of renegotiation of some of these PFI contracts in relation to the interest rate, which I think was thought to be unduly onerous. I'm not quite sure how government managed to renegotiate some of the contracts. Is that a possibility, or are these sort of totally legally fixed contracts that can't be varied in any way?
A PFI contract is by definition a legally fixed contract.
But I think the government did manage to. I mean, this was a big issue which the current one of the current transport ministers took up when he was on the backbenches a couple of years ago, with I think some success.
I think the bigger issue is, and we are working to support trusts with this, to make sure that within the existing contracts, those contracts are managed really well and value for money is delivered. If you bear in mind that a PFI contract typically includes facilities management services bundled in as part of the life cycle cost and the unitary payment, it's really important that the trusts deliver value from that. And so we are supporting that, and data is available to understand whether people are getting decent value from that. I'm less excited about the prospect of wholesale renegotiation and refinancing, if I'm honest.
Okay, thank you.
Thank you. We'll come on now to mental health and Lisa.
It's a question to Ian. Is the current data available on spending and performance of mental health services fit for purpose?
I think it's getting better, but there's more to do, would be my line. So one of the things, reflecting on some of the comments earlier, the NHS has been working very hard over the last couple of years, and I think it will continue to do so in the long-term plan, to put more priority on mental health, and that means more money going into mental health services. I think so far we've started working with NHS England much more to try and track the investment, and I think there is real evidence that the investment going into mental health across the country in terms of the mental health investment standard is being met. That's NHS England's responsibility, but they're tracking that. We also want to track, though, where that money goes and it getting to the front line, because at the end of the day it's what goes in at the top to commissioners and then what comes out in terms of services, and I think we're making progress on that, and I think there is evidence that that investment is starting to pay real dividends. I think if you look at things such as the improving access to psychological therapies, there's been a huge investment in that. Now, whether it's that or whether it's young people's mental health services, it's very clear that there's more to do, and that a significant focus of the long-term plan needs to be on continuing to do that. Alongside that, we absolutely have to have metrics to understand where the money's going, picking up on the point made earlier, where the workforce is for this, and therefore whether patches are able to drive their services forward. Things like out-of-area placements, important within that as well. So I think we're getting there.
The IAPT wasn't that ring-fenced, though. Is that not further argument then for ring-fencing of mental health funding?
I think what is probably more important than a ring fence, which, I noted Richard's comments about, the consequences of ring fencing, is the extent and this will be a test for the long-term plan, that we're clear and transparent about the investment in mental health services as a proportion of the overall NHS budget. And I think that will feature in the long-term plan, and I'm strongly expecting that there will be a very significant focus on mental health.
Okay. And if we don't get to the stage where we're clear that the investment goes where it should there then be a ring fence?
I think the technical arguments about ring fence for me are less important than what services are being bought, how long do patients have to wait for them, and what's the workforce that's delivering those services to patients. And that, I think, is the guts of the argument, really.
But I worked in mental health for 20-odd years, and the money often doesn't come. It's promised and then it doesn't arrive. So doesn't there come a point, if all of the other data isn't adding up, that you say, well, actually, we do need to make sure the money is going where it should, to the front line of mental health?
Well, as somebody who in their early career worked in mental health as well, I'm naturally sympathetic to the argument that we need to make sure the money gets through to the front line. And I think ultimately that's NHS England's responsibility, but we will work with them, we are working with them to track the cash through from the investment, and the fact that the mental health investment standard is now being met across the country as a start point. But we're also tracking what that's then spent on, so that we can see the services that people who have needs are actually getting. And the metrics around that were talked about earlier will then give us a sense of how quickly they're getting those services. So I don't think we should underestimate the priority that's going to be attached to this.
Thank you, Chair. If I can add to this. So in a local system, there are 4 contributors to the mental health fund that serves people across all ages. There is the NHS budget, which is typically the larger sum. Then there's adult social care, which is about 15 to 20%. Children's services put another 5 to 10% in, and then something from public health. So if you think about the whole quantum available to a local population to meet all age mental health services, it's important to understand how that works together. Take tiers 1 to 4 on CAMS. Would you spend more on tier 1 or tier 4? Well, probably tiers 4s and 3, which is the more preventative angle. You might bring in some of the public health money to do some of that, looking at whether children's centres could do some work that traditionally might not have been funded by public health, but could be a very useful vehicle for better meeting children's and families' needs. So understanding how population-level budgets meeting a particular need works is probably the ascendant ethic compared to what does my data tell me, what does Ian's data tell him. I'm not sure that resonates anymore.
A lot more in terms of mental health for older adults, say, in social care, because it seems that services are so stretched, people are going in and out in 15, 20 minutes, that's contributing to loneliness and actually eroding people's mental health, and the other community services have been eroded too that used to cater for it.
I think it was only a couple of weeks ago that the Prime Minister herself basically said it was one of the greatest challenges currently facing colleagues in public health. I think that's true for us all, because we know there's a connection between loneliness and mental health. We know that there's a connection between loneliness and requests for service and support that aren't always necessary and are sometimes far more than is required. But of course, where does the resource come to address that?
Day centres and things that they could go to socialise and that reduce loneliness, and those have all been closed basically, and so people are getting this 15-20 minutes a day, which may cater for some physical needs, but it's certainly not going to do very much in terms of their mental health if they're sitting looking at 4 walls all day, surely.
And I couldn't agree more with you. If the government was prepared to give us long-term sustainable funding beyond short-term, temporary and frankly inadequate resourcing, that probably next year looks like 2.35 billion. Some of that just might change But until it does, people will continue to get levels of service that you or I wouldn't want ourselves in a number of cases because councils are just too far stretched.
Thanks. So that makes three of us. And I guess perhaps coming back to Diana, your request for innovative examples of where things have happened and my points about local systems and DPH, for instance, being part of that. I chaired a group in London called Good Thinking. We managed to get all CCGs funding it and over half of local government funding it. We had support from Public Health England and we also had national NHS people, and we developed what was an innovative, digital-based mental health and well-being service to help people with low-grade anxiety and depression where they are. And where they are is in their homes, and they're on their laptops, they're on their phones. And what we did is we developed a platform with people, with users, with all that expertise, in an innovative new way of doing public sector services, which is basically helping people where they are to help themselves, finding them, inviting them onto a platform where there were NHS-accredited apps that they could use, and we're also developing a peer support so that they could get help where they needed in their home at midnight when they couldn't sleep, for instance, rather than always relying on a public sector service or their GP or their NHS. And so we know how high a level of need there is with low-grade anxiety, depression, OCD, those kinds of problems. So how do we innovate our public sector services to really meet people where they are, be really user-friendly, using digital in that way? That's very much about prevention and people helping themselves and then bringing in that peer support. Now, that whole approach is quite labour-intensive to get off the ground because there's so many organisations, goes a little bit back to the silos, but with proper system leadership and bringing people together and willingness and then funding, we can actually really transform the way we're doing services and we're meeting people's needs. And that's how we can really try and help make the NHS sustainable. But that needs funding in other places to help make that happen.
Thank you. Can I come on for a final section now to workforce? And starting with yourself, Ian, can I just ask, first of all, have you been given any steer on the scale of the transfers from HEE to NHS England budgets?
Transfers from NHS?
From Health Education England budgets to NHS England budgets. Because we've seen the wider gap there is between the budget going into NHS England and the wider DH spend. Are you expecting to see a transfer out of HEE budgets?
We're expecting something a bit different to that, which is, our plan depends upon having the money in Health Education England to train the new and increased numbers of staff we need. We don't yet know what the Health Education England settlement will be. That's clearly important. But
how difficult is it for you to make a long-term plan if you don't yet know what your budget's going to be?
Let's take a step back. So what we see is that we've got around 100,000 vacancies in the NHS, and I think from memory at the Q1 period, that was about 37,000 nursing vacancies. Now, to be fair, the vast bulk of those shifts are being met, but they're being met by temporary staffing, which is unsustainable. And what we know is that over the next few years, demand for staff, both in the community and in hospitals, will grow because an ageing population will need more healthcare. Therefore, the basis on which we are planning is to have a look at what actions we will take so that over the medium term we cease to have a deficit in staff in medicine and nursing, as two examples, but there are other professions as well. And what would you have to believe? What would be the actions that we would then need to have in place? Now, we can get into some of those in a minute if that's where you want to take the conversation, but one clear assumption is that we have to increase the number of training opportunities for nurses in particular, because otherwise we will continue to have a deficit. And so the assumption we've got to work on is that the costs of those training places and the placements to support them will need to be met. Obviously, that is an important determinant, just as with social care and public health, as to how we use the NHS settlement over the next 5 years and then the NHS next 5 years, because otherwise we will have to manage with an ongoing deficit. So that's a big assumption, but I haven't got clarity on what the HE budget is. It's really important.
Very, very difficult for you to plan how you're going to achieve that, doesn't it?
I guess it's Simon Stevens and my job to set out what we think the NHS needs. But, of course, we are doing that in the absence of the knowledge about how much money there will be in HE.
Last time there was a big cut to HE budgets, that meant that it was all taken out of bursaries. So we saw an end to bursaries, and we're already seeing the impact that is having, particularly on mature students going into nurses, and the impact of, particularly with that group, who were the group that were most likely to stay. So it is a serious worry, isn't it, that you're not seeing the expected increase overall?
It's critical to the NHS. It's really important. The 3.4% and our ability to reshape the National Health Service to both offer access in hospital where it's needed, but picking up on some earlier comments, to invest in primary and community care and to have the staff to do that, to say nothing of mental health, is learning disabilities. I did start my career, my first job was in learning disabilities, so yes. That is dependent upon us moving from a situation of deficit to a situation of balance, and preferably a small surplus over a number of years. Clearly in the intervening period, because that is one critical component, there are a whole range of other short-term actions that we need to take to start making a difference in the intervening period. But the HE budget and the adequacy of it to support a new number of training places for both certainly nurses but also doctors is really important.
Because it's not just about training, is it? It's about retention. We held an inquiry into the nursing workforce, and one of the most critical points we was hammered home to us was about retaining your existing staff. And we're just not doing a good enough job with that, particularly around the impact of things like continuing professional development. So if, as we're anticipating, you're faced with a cut to the Health Education England budget, will you be using the wider NHSE budget to actually make up the shortfall, and how are you going to make that work?
I think the short answer, and I guess sounding a bit like a broken record here, but I'll say it again, is that would not be our intent, for the same reasons when we talked about social care and public health.
Get yourself into a vicious cycle then of having a further workforce shortfall and all the extra costs that will put on you from temporary and agency staff? Well,
that would be a very undesirable place for us to be. I think I would absolutely accept that. Our job in the long-term plan is to set out the numbers of staff we will need to run the NHS during the next 5 years and to make an improvement on the deficit of staff that we've currently got. That does include retention, but absolutely it requires more investment in training places, and retention, as you rightly say, also depends on the ability to develop your career. So there are some actions for us about being a better employer that we have to do to help staff feel valued. We're going to need some international recruitment, and that's going to have to increase over the short term. But ultimately, we're going to have to train more. I note, for instance, that there were 14,000, I think I'm accurate with that number, applicants for registered nursing degrees in the 2017 year that were not successful in getting onto places. So the bottleneck of training places is going to be very important over the period. But I come back to the fact, and I don't want to sound at all like a broken record on this, the NHS is going to need the 3.4%, and that was the basis on which the settlement was agreed. However, we also need, just as with capital, just as with social care, just as with public health, we also need an adequate settlement for health education in England.
Broken record either, but if you do find, and you've indicated to us you've not been told what the HE budget will be, whether it will be cut, and if so, by how much, surely that makes it very difficult for you to make a long-term plan when the long-term plan is so dependent, and the workforce is critical to that. Is that something that you're making clear to those who are thinking of cutting it?
I'm making clear that the adequacy of the budget to train our people is really important to us, and I'm really clear that in doing the modelling of the long-term plan, we have to ensure that the thing adds up. It adds up financially, it adds up in terms of capacity, thinking about Mr. Bradshaw's question about capacity earlier, and it has to add up in terms of workforce. Otherwise, it's going to, it would be pretty incredible.
Your modelling, and within that modelling, are you making what assumptions are you making about what's happening to the HE budget? We're
making an assumption that we will be able to increase the number of training places commensurate with the need over the next 5 years.
So you're making an assumption that you're not going to have cuts to HE budgets?
That is the assumption we're making.
And what if then next year, after you've launched your long-term plan, you find that there has been a cut to HE budgets? What will happen then?
In the short term, if the budget for training was cut, arguably not too much in terms of the plan for next year, because the plan for next year requires a range of activities that necessarily are shorter in length than the typical length of either of nurse training, let alone medical training. But over the period of the plan, if the number of places for training is not enough, then we will have to fill the gap through temporary staffing or even more international recruitment. But we're already having to step international recruitment up in the short term anyway.
And of course your costs for international recruitment are about to get a lot greater if we aren't able to recruit from the European Union, which is obviously a relatively low cost to recruiting from elsewhere. Are all these aspects going to be set out very clearly in the long-term plan? Because you may find you're having to rejiggle the entire plan if you end up with a huge workforce training gap.
The importance of workforce to the plan is, as we've discussed, really critical. I think the point about...
sorry? Do you have a plan B? In other words, you're proceeding as if there's not going to be a cut to HEE, but everyone is expecting that there will be a cut to HEE. Is that something you're factoring in at this stage to say how will it look if there is a cut? I mean, I find it extraordinary that no one's given you any steer on this.
The reality is, if the argument, we will set out the number of nursing staff that we need to do the work that we know we're going to have coming through the door, and for the new models of care for the patients in the community and in hospital. If it turns out that the number of training places is going to be inadequate, we will still need the same number of staff. We'll have to source them from elsewhere, and that would be more difficult. Within the next 5 years anyway, we have to start eating into the nursing vacancy level, because I think the Health Foundation has set out a do-nothing option, which is unattractive. And we can talk about the numbers, but the direction is clear. So we will have to recruit more staff over the next 5 years, including more nurses from overseas under any scenario. But clearly we'd potentially have to do more than that.
If you could set us out a note about the extra costs of recruiting from outside the EU, or indeed once Britain, or if and when we leave after the transition period, how much that will impact your costs, given the extra bureaucracy, it would be very helpful. And I think also going back to a point that Jeanelle made earlier about the loss of expertise in public health, Is that something you're going to specifically look at as well within your workforce plan?
I think it's something that Health Education England, I'm sure, will want to look at more generally. Public health workforce is an important component of that. I think it's it'll be there are a whole range of workforce professional issues. We could talk about nursing. We could talk about certain specialties of medicine. We could, we could talk about any of those things, I think.
And then just my final point, because I know Lisa wants to come in on this as well. Will the enhanced joint working between NHSI and HEE involve any pooling of budgets or other resources?
We are not at that stage. We are clear that the link between Health Education England, which has the expertise for commissioning training places, and NHSI needs to get much slicker, because there's been a disjoint, I think, between long-term workforce planning and long-term service planning. And as we talk about a long-term plan for the NHS, the NHS is the people. It is a people-based business. And those two things need to be aligned so that we actually deal with this together. We're working very closely with HEE, looking at the necessity for staff over the next 5 years, and I would imagine that closeness will continue to increase.
Extraordinary that you can go forward with a 10-year plan without actually understanding what your workforce budget is going to be. But anyway, Lisa.
It's just to follow on from that. Shouldn't we be asking for an increase in funding for training rather than standing still, drastically? Because actually, the whole Brexit thing has shown how unself-sufficient the UK is in terms of the NHS, in terms of health and social care. And there's so many good people out there who apply for medical training, who want to be nurses, who want to be doing these jobs, who are refused. And shouldn't we be aspiring to something better than just running to stand still?
Yes, I think in a nutshell we should, and I think that's what I've been saying we need to look at for the next few years. We need to get to a situation where we train enough of our bright, young and not so young people to be the healthcare professionals we need. And in the short term, we will have to use more international recruitment. But we need to move beyond that. And while an element of that will probably always be there, fundamentally, we need to grow our own. The response, I suppose, to Dr. Wollaston, though, is let's just remember what the settlement is with the NHS. The NHS has had its settlement, and it's our job to set out what we do with that. As we've heard over the last hour or so, the link between the settlement we have and the other budgets on which the health service depends is well made. And certainly I'm not here saying that that is in any way not important, because we need those budgets to be right.
Further to that, obviously the social care workforce and and particularly the nursing workforce within social care, the impact, the disparity between the pay awards. Would you like to comment on that, Glen?
Yes, indeed. And your point about how difficult it is to have a long-term plan. My colleagues this year will have to save £700 million. My colleagues next year will have to save another £500 million ongoing as a result of austerity. That will have a bearing on how services look and what the nature of those services are over the coming 2 years, unless we get a long-term funding settlement. And what we've got today is nowhere near close enough. So if we look at three particular groups in our workforce, care workers. We know that there are a number of care workers who will seek to go into healthcare work. And of course, if you have a better pay offer of some 29%, which is the consequence of agenda for change, where will you go? How can councils possibly compete with that unless there's parity of esteem? We've already heard that. Retention is a really major issue for colleagues providing home care services. And particularly younger people, particularly those who are male, and most of them want a career structure that looks better than the one they've currently got offered. Unless we're able to put money into domiciliary care, we will start to lose more people, and the consequence of that will be felt in the hospitals. And we will not be serving people in the community where the bulk of the service lies, not on the acute side. If we look at nurses, a nurse can work in the community, in a nursing home, in a hospital. Some of the more advanced thinking suggests that if you look at nurses as having placement opportunities across those three sectors, there's a better chance of retention. There's a better chance of a more rounded nurse offer in those local areas. And some systems, my own included, are beginning to look at the acute trust, the community trust, and my social care providers working together, not only to recruit, but to retain nurses on placement, because they can work across the three sectors. And then let's look at different skill mixes. Nursing associates. What do you need to do a nursing task isn't necessarily a nurse. But you need a level of clinical oversight. But it also provides potentially a career structure for people in the sector who are so desperately in need of them.
Nursing associates.
So all that you can do, Chair, to promulgate the importance of some of these overlaps will help all of us deliver something better than what we have today.
And where is the barrier? Because, I mean, we heard that clearly, that actually if you provide a better career structure and rotating placements across health and social care, what is the barrier that stops that happening in practice?
If I quote the CQC, the more successful systems are the ones where the relationships are good, have a long-standing base, and where colleagues are prepared to look across the piece at how do we improve systems for local populations. If we look at in our particular bubbles, at our particular issues, we will singularly fail. And that's particularly true of the care workforce, which, let's face it, it's bigger than the NHS. It just happens to be a distributed model that you don't see wearing kit that has a certain totemic value, but does just as skilled, just as dedicated work.
Lack of nurses working in district nurses and in the community ends up with people in more expensive settings in hospitals, I guess. So, thank you. Well, are there any points that any of you wanted to make that you haven't been asked about this afternoon around the budget? No. Thank you very much for coming.
The proceeding has ended. The proceeding has ended. The proceeding has ended.